Welcome to this study guide on pneumothorax. Before we begin, an important note. This presentation is designed as a learning resource for medical students and residents. It is not intended to serve as a clinical treatment guide. With that in mind, let's review the diagnosis and management of pneumothorax in a structured, exam-focused format. Let's begin with the major causes of pleural air intrusion. Spontaneous pneumothorax occurs without direct trauma. It may be primary in patients without known lung disease, or secondary in patients with underlying pulmonary pathology. Iatrogenic pneumothorax results from medical procedures, including thoracentesis, bronchoscopy, or placement of a central venous catheter. Finally, traumatic pneumothorax follows either penetrating or blunt chest injury, or may occur during mechanical ventilation when excessive pressure damages the lung. A key distinction is whether the event is primary spontaneous or secondary spontaneous. In primary spontaneous pneumothorax, the patient has no known underlying lung disease. It classically occurs in tall, thin individuals and is associated with factors such as cigarette smoking, Marfan syndrome, and occasionally cocaine use. In secondary spontaneous pneumothorax, the patient has an underlying pulmonary disorder. Common pathological drivers include COPD, cystic fibrosis, interstitial lung disease, pneumocystis, Jirovecii pneumonia, and lymphangioliomyomatosis. This distinction is important because secondary pneumothoraces generally carry greater risk and often require more aggressive management. Patients typically present with the sudden onset of shortness of breath and unilateral chest pain. The pain is often described as sharp or pleuritic, although some patients report a persistent pressure sensation. On examination, you may find unilateral decreased breath sounds, hyperresonance to percussion, and reduced tactile fremitus. Cardiac auscultation may reveal distant heart sounds when significant air accumulation is present. Remember the important exam points shown here. Physical examination can be entirely normal when the pneumothorax is small. When a patient presents with unilateral chest pain and acute shortness of breath, several potentially catastrophic conditions must be considered. The differential diagnosis includes acute pulmonary embolism, myocardial infarction, aortic dissection, pericardial tamponade, pleural effusion, and pneumonia. Pneumothorax is therefore one of several time-sensitive cardiopulmonary diagnoses that must be rapidly evaluated and distinguished. The diagnostic standard is an upright chest radiograph. The hallmark finding is the visceral pleural line. Diagnosis is confirmed when this pleural line is seen separated from the chest wall, with an absence of normal lung markings beyond that line. Recognizing the visceral pleural line is one of the most important radiographic skills when evaluating suspected pneumothorax. Management depends on three major factors: the defect size, the severity of symptoms, and the patient's hemodynamic stability. Small pneumothoraces with minimal symptoms generally follow pathway A. Larger or more symptomatic pneumothoraces proceed to pathway B. However, if a tension pneumothorax is present, the patient immediately enters the emergency override pathway, where life-saving intervention takes precedence over routine evaluation. For small pneumothoraces, treatment is often conservative. The primary intervention is observation combined with oxygen therapy. Supplemental oxygen lowers the partial pressure of nitrogen in the blood, creating a gradient that promotes gas reabsorption from the pleural space. Under favorable conditions, the trapped air may be reabsorbed at approximately 8 to 9% per day. Therefore, many small, stable pneumothoraces resolve without invasive intervention. When the pneumothorax is larger or the patient becomes significantly symptomatic, active evacuation of pleural air is required. Two common options are simple aspiration and insertion of a small bore chest tube. The goal is straightforward: remove the trapped pleural air, allow lung re-expansion, and relieve symptoms. Choice of technique depends on patient factors, local expertise, and institutional protocols. This slide highlights the classic features of tension pneumothorax, a true medical emergency. Three critical warning signs are tachycardia, hypotension, and tracheal deviation. These findings indicate rising intrathoracic pressure with impaired venous return and cardiovascular compromise. The key message is simple: recognize tension pneumothorax early, because delayed treatment can rapidly become fatal. Once tension pneumothorax is suspected, management must be immediate. Do not wait for radiographic confirmation. Perform needle decompression of the pleural space using a 14-gauge needle. The traditional landmark shown here is the second intercostal space at the mid-clavicular line. The objective is rapid pressure release, restoration of venous return, and stabilization of the patient before definitive chest tube placement. In secondary pneumothorax, clinicians must remain alert for a persistent bronchopleural fistula. Persistent air leaks and recurrent pneumothoraces are much more common in secondary disease than in primary spontaneous events. If an air leak continues despite standard drainage, strongly consider an underlying bronchopleural fistula as the root cause. Identifying this complication is essential because it often changes subsequent management. Patients with recurrent pneumothorax require strategies aimed at preventing future episodes. One option is structural intervention, such as chemical pleurodesis, which promotes adhesion of the pleural surfaces and reduces future air trapping. Equally important is behavioral intervention. Smoking cessation is critical because smoking significantly increases recurrence risk. For examinations and clinical practice alike, recurrence prevention is an important component of long-term management. Let's conclude with the clinical master algorithm. Start with the etiology: spontaneous, iatrogenic, or traumatic. Assess the key examination findings, particularly shortness of breath, hyperresonance, and unilateral chest pain. Confirm the diagnosis using the visceral pleural line on chest radiography. Management then follows severity. Small pneumothoraces may be observed with oxygen therapy. Larger pneumothoraces generally require aspiration or chest tube placement. And any patient with tension pneumothorax requires immediate decompression, followed by definitive drainage. Finally, address recurrence prevention, including pleurodesis when indicated, and strong counseling for smoking cessation. That completes our structured review of pneumothorax diagnosis and management. This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence. The contributors to this video have exercised due diligence, but the content may become outdated quickly.